Hello, my name is Stuart Kimball. I'm a long-run athletic training student, and today I'll be presenting on rhabdomyolysis, or more commonly known as rhabdo. Picking apart the word, rhabdomyolysis in itself means striated muscle breakdown. Criddle reports that rhabdomyolysis is dissolution of skeletal muscle that produces a toxin that can be harmful and or destroy the kidneys by putting the kidneys into acute renal failure. Criddle reports that it can cause electrolyte imbalances, hypovolemia, metabolic acidosis, and renal failure. Criddle also reports that rhabdo can be caused by the stress to the skeletal muscles and is typically seen in athletes that exercise or perform in hyperthermic conditions. Safari explains that creatine phosphate kinase, CK, an enzyme that is used in energy production, can be used as a progenitor factor of rhabdomyolysis. My PICO question for my research is, in male collegiate athletes, are the signs and symptoms of rhabdomyolysis as trustworthy to indicate rhabdomyolysis as elevated CK levels? So this can be viewed one of two ways. Are the signs and symptoms enough to clinically diagnose rhabdomyolysis? And two, are there pre-screens and or baseline tests that need to be performed to mitigate the risks of rhabdomyolysis or to easily identify rhabdomyolysis? The CK levels play a large role in rhabdomyolysis. As mentioned before, it is the way that rhabdomyolysis can be detected. CK levels are obtained through blood draws and lab analyzation. Criddle reports that the average CK levels of an individual are 45 to 260 units per liter. A study was conducted on a football team who performed two-a-day practices in the summer for preseason for roughly 2 weeks. They obtained a baseline CK level on day 1 and tracked the CK levels throughout the 2-week practice. It was shown that there was an elevation in CK levels throughout the whole 2 weeks, and that there was a higher elevation in CK levels on the first several days, and then it dropped slightly but remained elevated above the baseline. Clarkson states that the CK levels rise due to exertional muscle damage produced by extrinsic exercise and other stress that is placed on the muscles. Kanov reports that there is an increased chance of rhabdomyolysis in a hyperthermic environment, which many of the signs and symptoms mirror or mimic heat-related injuries such as heat stroke, heat cramps, and heat exhaustion. So some of those signs and symptoms include muscle weakness, tenderness, generalized malaise, and nausea. Although the most common sign, as described by Criddle, is a discoloration of urine. We all know that the clear urine indicates hydrated, the individual is hydrated, while a darker urine or more of a yellow tinted urine is one of a dehydrated individual. An individual that is suffering from rhabdo is actually going to experience urine that is quite dark, almost of a mucky brown to a reddish color. And a urinalysis will reveal that a person with rhabdo has a specific gravity or 1 greater than 1.025. And this shows that they have large quantities of excreted myoglobin in the urine. Excuse me. What happens as we go back to the breakdown of the word, striated muscle breakdown, the stress causes the micro tears, which then releases the myoglobin into the bloodstream, which is then filtered out by the kidneys as long as they're still working in rhabdo, and then urinated. While the CK levels are in the bloodstream trying to produce more energy to help with the energy level that is required for the exercise, which is why together the CK levels that are elevated, as well as the presence of the signs and symptoms, as well as the dark colored urine, both indicate that an individual has rhabdomyolysis. So in conclusion, and changes in the clinical practice, the clinical signs and symptoms should be used more as a tool rather than a gold standard of clinically diagnosing. If an individual is presenting with the general signs and symptoms as well as a dark colored urine, um, then they should be referred to a higher level of care to obtain those labs and obtain the CK level to identify the rhabdomyolysis if it is present. So what we can conclude from this is the baseline, and what I mean is refer to baseline is if the available resources to the healthcare provider are present, they should perform baseline on all individuals or just those that are at risk. And these at risk individuals should be those that have one experience and self-report of heat-related injuries in the past, or those that the healthcare provider or athletic trainer has dealt with individuals in prior seasons or other instances. These baselines should include a baseline level of CK levels so that they can be compared to the obtained CK level, and a quicker comparison can be concluded rather than just based off of that 45 to 260 units per liter. That way they can treat the individual faster. As well as a preseason screening should include a urinary analysis dipstick test to obtain the proteins that are in the urine as a baseline, which then goes back to that 1.025, which shows the large amounts of excreted myoglobin in the urine. That concludes my research on rhabdomyolysis. Are there any questions?